Schwannoma is one of the most common intracranial tumor, and of the schwannoma, 80 to 90% arise from vestibulocochlear nerve. So this vestibular schwannoma are also known as acoustic neuroma, but the better terminology is vestibular schwannoma. And you know that the Schwann cell, they form the myelin sheath of axon. So actually it is a nerve sheath tumor. Okay. And in the next few minutes we will go through the origin of vestibular schwannoma, etiology, pathology, diagnostic modalities, and also the treatment options of vestibular schwannoma. And this vestibular schwannoma arises from, most commonly it arises from the superior vestibular division of vestibulocochlear nerve. It can also arise from inferior vestibular and also from the cochlear nerve, but the most common site of origin is from the superior vestibular nerve. Okay. And you know, this is one of the most common tumor arising from cerebellopontine angle or the CP angle. So what is the CP angle? What is the anatomy of the CP angle? So you know this, there is anterior cranial fossa, then we have this middle cranial fossa, and along with the anatomy of temporal bone, we discussed that the petrous part of temporal bone forms the boundary between the middle and the posterior cranial fossa, isn't it? So this is a link for anatomy of temporal bone. Please go through that. And here also this part is the petrous part of temporal bone. And of the CP angle, medially it is formed by the brain stem. Okay, so the pons and also the brain stem forms the medial part of CP angle. Laterally it is formed by the petrous part of temporal bone. And posteriorly you have the cerebellum. Okay. So this part is CP angle, medially by the brain stem, posteriorly by cerebellar peduncle, and laterally by petrous part of temporal bone. And in the petrous part of temporal bone, you know, there is internal acoustic meatus also, internal acoustic meatus, and fundus of internal acoustic meatus, the nerves are superior, inferior, anterior and posterior, divided into an upper and a lower part by crista falciformis, and the upper part is again divided into anterior and posterior by the Bill's bar. So here you have the anteriorly 7th nerve, then superior vestibular nerve, and below by the cochlear nerve and also by the inferior vestibular nerve. So acoustic neuroma or vestibular schwannoma usually arises from the superior vestibular nerve. Okay, that too in the CP angle. And the most common tumor, around 80% of the tumors of CP angle are most common. One is a vestibular schwannoma. So, and in the CP angle, you have this 7th and 8th cranial nerve going into through the internal acoustic meatus. So 7th and 8th cranial nerve, and also there is lower cranial nerve. They are the 9, 10, 11, 12, and also towards the apex of petrous part of temporal bone there is trigeminal ganglion and also 3, 4 and 6 cranial nerve. Okay, so there is trigeminal 5th one, 3, 4, 6, then 7, 8, and towards the inferior part there is also the lower cranial nerve, and it contains CSF and also arachnoid tissue, these nerves and the accompanying vessel. So this is anatomy of CP angle, and vestibular schwannoma most commonly originate from the CP angle. And what is the cause of this CP angle tumor or the vestibular schwannoma? The exact etiology is not known, and the recent advances in molecular biology shows that it is an association between the defect in chromosome number 22q, that is long arm of chromosome number 22. And in most of the cases this is unilateral. These vestibular schwannomas are unilateral, but less than 5% of cases it is bilateral. Okay, and this bilateral vestibular schwannoma has got a strong association with the neurofibromatosis type 2, and 80 to 90% of neurofibromatosis type 2 is genetically linked with the neurofibromatosis type 2 is autosomal dominant inheritance, and 80 to 90% of this NF2 is associated with a bilateral vestibular schwannoma. Okay, so more commonly it is unilateral and sporadic. Exact etiology is not known, but there is an association between the defect in chromosome number 22, long arm of chromosome number 22, and of the bilateral neurofibromatosis type 2 is strongly associated with the bilateral vestibular schwannoma. And in the histopathology, three important findings. One is an Antony A cell. Then there is an Antony B cell. And there is also Verrucke body named after Jos Juan Verrucke, who first described that. Verrucke body. So Antony A is this one, Antony A cell, that is a densely packed cell with a spindle shaped and deeply staining nucleus, that is Antony A, and two rows of Antony A with an acellular zone. Okay, so two rows of densely packed Antony A cell with an acellular zone is a Verrucke body. And these are the Antony B cell, that is the looser cellular aggregation of vacuolated pleomorphic cells here. So densely stacked one is Antony A, and looser cellular aggregations of vacuolated and pleomorphic cell is Antony B, and two rows of Antony A with an acellular zone in between constitute the Verrucke body. So these three are highly characteristic of vestibular schwannoma, and in any cell pattern can predominate, or there can be mixed cell types in a single case of vestibular schwannoma. And how can you diagnose a case of vestibular schwannoma? So the diagnosis is mainly from the symptom and examination and some investigation findings. We can get an early diagnosis by taking a thorough history and examination of the patient. And the symptoms depend upon the size of the tumor and also the exact location of the tumor. For example, if it is arising from the internal acoustic meatus, so 7th and 8th nerve are there, so it can lead to an sensorineural hearing loss and also tinnitus. But if it is involving the CP angle only, this unilateral sensorineural hearing loss may not be there. Okay, so the symptom depending upon the location and size of the tumor. And the most common symptom in more than 60% of cases, you will get a sensorineural hearing loss, which is unilateral, very slowly progressive, mainly for higher tones, and also there will be poor speech discrimination. Okay, so sensorineural hearing loss, which is unilateral, slowly progressive, more for higher tones and also poor speech discrimination, as it is a retrocochlear pathology. Okay, and associated with that there will be tinnitus also, and a very minimal degree of disequilibrium will be there. And if the tumor is enlarging and if it is compressing on the cerebellar peduncle, then there will be more of disequilibrium and also there will be ataxia. Okay, and if it is going, here there is fifth nerve, If it is going and compressing on the fifth nerve, what will happen? There can be midfacial and corneal hyperesthesia can happen, and then if even it is enlarging more, they can have, the patient will be having headache also. And then if it is filling this entire CP angle, this can compress on the lower cranial nerves, so it can present as voice changes, or it can present as aspiration, dysphagia, nasal regurgitation, etc. Okay, and still it is growing. It can lead to hydrocephalus and also limb weakness of the limb, one side of the body, etc. can happen. So the most common one is sensorineural hearing loss and tinnitus, and the rest depend upon the size of the tumor and also the parts compressed by that. Okay, and of the early tumor, if there is corneal reflex is absent, it pointing towards a fifth nerve involvement, and another sign is a Hitzelberger sign. What is that? It is usually asked as, so many MCQs can be asked in this vestibular schwannoma. Hitzelberger sign. It is one of the earliest symptoms of vestibular schwannoma, where there is hyperesthesia of the posterior-superior part of the external auditory canal. Posterior-superior part of external auditory canal is supplied by sensory division of facial nerve, that is nervus intermedius, sensory root of facial nerve, not the motor involvement, only the sensory part. This is described in detail along with the Rufford autalgia class. Okay. Hitzelberger sign is an hyperesthesia on the posterior-superior part of external auditory canal due to involvement of nervus intermedius or the sensory root of facial nerve. There is no involvement of motor part of facial nerve. So as such, a facial palsy will not happen in an earlier case of acoustic neuroma. And if you are getting a patient with a facial nerve palsy, you can think of other lesions in the CP angle like a meningioma, a primary cholesteatoma, etc. Okay, so the most common lesion in a CP angle is vestibular schwannoma. The next three commonest one is a meningioma, then comes the primary cholesteatoma, then third is a arachnoid cyst. So if there is motor involvement, think of a meningioma, and in vestibular schwannoma, the stretching of the facial nerve will not happen, so sensory root involvement will be more. Okay, so these are the symptoms and signs of a vestibular schwannoma. What are the other diagnostic modalities? So in the diagnosis, the 5 important headings are there. As I already explained, one is symptom, then the sign, that is examination finding, complete examination, especially the neurotology examination with special emphasis on nystagmus. Look for spontaneous nystagmus, gaze-evoked nystagmus and vertical nystagmus. In most of the cases, in early stages, you will get a horizontal gaze nystagmus, a horizontal gaze-evoked nystagmus with fast component away from the affected ear. And when in the late stages, when there is involvement or compression of the brainstem and cerebellar peduncle, you will get a vertical nystagmus also. Look for Romberg's test for cerebellar involvement, dysmetria, fine movement, gait, heel shin test. I already discussed that corneal reflex, importance of corneal reflex, and also Hitzelberger sign, and also examination of lower cranial nerve. And then the third is audiometric testing, fourth is vestibular test, and fifth one is imaging. Next is audiometry test. First one is pure tone audiogram. Definitely you will get a sensory neural hearing loss with a disproportionately poor speech discrimination. And using a impedance bridge, you can do a stapedial reflex decay test, and a decay of half amplitude in less than 5 seconds or less will point towards the retrocochlear pathology. Then the most sensitive one is an auditory brainstem reflex. In large tumors, you will get the more than 90% sensitivity is there. So mainly wave 5 pattern is looked upon. Wave 5. Okay, so an interoral wave 5 latency of more than 0.2 milliseconds or a prolonged 1 to 5 interwave time interval or a complete absence of wave 5 is indicative of an vestibular schwannoma. But in a very small intercanaliculus, if the tumor is very small and it is located within the internal acoustic canal, then the sensitivity of ABR is very less. In that case, you can go for a stacked ABR. Stacked ABR, and this has got around 85 to 90% sensitivity and more specificity in case of intracanalicular small and early vestibular schwannoma. Okay, so these are the audiometric tests. Vestibular study. So this vestibular schwannoma is a very slow growing tumor. So this will affect the vestibular nerve of the affected ear very slowly. So at the same pace, compensation also occurs. So that is why the patient is not complaining of a frank vertigo. Rather, the patient will complain of an unsteadiness or a clumsiness. So you can do a caloric testing, and the cold caloric testing is also done, and also electronystagmography will give you a graphing of, you will get a graph of nystagmus. But this is not at all done nowadays because of the more precise imaging modality. Of the imaging modality, MRI scan with the gadolinium enhancement is the investigation of choice in a case of vestibular schwannoma. But if the MRI cannot be done due to presence of any implantable medical device such as a pacemaker, then we can do a CT scan. For that, 1 to 1.5 mm cuts of CT scan in both axial and coronal plane. And in any person, the internal acoustic canal of one side will vary from 1 to 12 millimeters. But the two canals of any individual will be almost identical. So in case of a very early intracanalicular tumors, and also to get a bony details of the temporal bone, this CT scan is very good, and that forms the basis of Valvasore's criteria for the diagnosis of vestibular schwannoma. You have to do comparison with the two sides, and enlargement of 2 mm or more of internal acoustic canal of both sides, or shortening of the posterior wall at least by 3 mm in comparison with the canal of normal hearing side. It is pointing towards an intracanalicular vestibular schwannoma. And the gold standard in the diagnosis is an MRI with a gadolinium enhancement. The diagnostic tool of choice is MRI with a gadolinium enhancement, giving a 100% diagnostic yield. Okay. So in that you get, this is very useful in case of very small intracanalicular tumors also. And if in the internal acoustic canal, you know that the lateral aspect is more porous, and this is extrameatal part, and this is fundal part. So towards the fundus, if it is involvement is there, it gives a trumpeted internal acoustic meatus sign, because there will be widening of the fundal area. Towards the fundus, if there is widening, we call it as a trumpeted internal acoustic meatus sign. And if the extracanalicular part is involved, see, it will lead to an ice cream cone sign. Okay, so if it towards the lateral part, fundus is involved, it will give a trumpeted internal acoustic meatus sign in MRI. And if the extrameatal segment is involved, it is more involved, widening is there, it give a ice cream cone sign. And in T1 weighted, we get a hypo to iso intense signals, and in T2 it will give an heterogeneously hyper intense signals. Okay. And the recent advance is a fast spin echo MRI, FSE. The residents can prepare on that, because you can expect a question in recent advance. This is in FSE, the dye involvement, dye injection is not needed. This is comparatively cost effective. It can be used as a screening tool. Okay, so fast spin echo MRI is a recent advance. So this one is the MRI with gadolinium enhancement is the the investigation of choice. Okay, so that is all regarding the diagnosis. And once you came to a diagnosis, what are the treatment options? The main and also the accepted modality of treatment is surgery, but we can also go for observation and also stereotactic radiotherapy. Okay, so the prediction of the tumor size is very important. Size of tumor, and generally this vestibular schwannoma is very slow growing tumor. The growth rate is calculated to be around 1 to 2 millimeter per year, but in some cases around 25 millimeter per year can also happen. So the one thing is observation, that is called termed as the wait and rescan policy. Wait and rescan policy, and the size of tumor is predicted by the tumor size at discovery, then age of the patient, growth in first 6 months of observation period, and association with the neurofibromatosis type 2. NF2 is associated with bilateral acoustic neuroma. So if unilateral acoustic neuromas, usually the growth rate is, if it is 3.5 millimeter per year, then bilateral one, the growth rate is slower. It grows around 1.5 millimeter per year. So these are the growth predicting factors. Wait and rescan policy can be done if the patient is old age with multiple comorbidities, and if the affected ear is the only hearing ear where there is a serviceable hearing and the size of tumor is very small. But in that case, an MRI has to be repeated at 6 months to 1 year follow-up period. Every 6 months to 1 year, the MRI has to be repeated. Another modality of treatment is stereotactic radiosurgery. We also known as gamma knife. Actually, it's a misnomer even then. In gamma knife, we use cobalt 60. And in X-knife we use linear accelerators, and the latest version of cyber knife where a computer assisted robotics is used for real-time radiation. Here, to a single target, multiple radiation beams are focused to a single target so that the surrounding areas will be least affected. And it was first introduced by a Swedish neurosurgeon called Lexen in 1951. Okay. So these are the advantages of stereotactic radiosurgery over microsurgery: decreased time of hospitalization, quick return to work, then can be done in elderly or medically infirm patient where surgery cannot be done. Risk of surgery like CSF leak or infection can be avoided, and this is very good in recurrence as a salvage radiation. And the disadvantages are, there is chance of a radiation-induced hydrocephalus, then malignant transformation of the benign vestibular schwannoma can happen, especially if it is done in young persons, and there is also a potential for sudden hearing loss. And the third modality of treatment, which is suitable for all size of tumor, is microsurgery, micro-excision, that is surgery, with using facial as well as auditory monitoring. And in that, mainly there are 4 approaches. One is a middle fossa approach, then translabyrinthine, then posterior fossa or retrosigmoid, and a combined approach. Of all these surgical approaches will be discussed in next classes. And there are, because we are knowing more about the molecular basis of vestibular schwannoma, there are some emerging modality of treatment, emerging or recent advanced treatment modality. Newer treatment modalities: bevacizumab, that is a monoclonal antibody, and a vascular endothelial growth factor inhibitor. This vascular endothelial growth factor is which aids in angiogenesis and will promote the growth of tumor. So that bevacizumab will stop the growth of tumor. And everolimus is again an mTOR complex inhibitor, and lapatinib is an EGFR or ERBB2 inhibitor. They are all under clinical trial sessions, but evidence shows increasing use of this, especially in a very large tumors, and also in patients where surgery or radiation therapy is not possible. Okay, so the treatment modalities are basically, one is observation, that is the wait and rescan approach. Second is stereotactic radiosurgery, and third is the definitive management, which is surgery. And these are the newer trends in the treatment of vestibular schwannoma.